So I think we move on now to the talk that I'm really looking forward to in this course. It's my honor and pleasure to invite on stage Professor Dr. Jagat sir, whom I've been learning from since many years, and today I hope to do the same. And he will be talking to us about the surgical paradigms of a pediatric cataract surgery.
First of all, I am thankful to Dr. Vaishali Vasavada and Dr. Abhay Vasavada for giving me this opportunity to participate in this instruction course. I will be speaking on the surgical tips for cataract surgery in pediatric eye. I always remember my teacher, because as the person grows senior, we remember that, because younger people, they forget their teacher. Because I am realizing I have experience of 44 years in the ophthalmology. So I owe my gratitude to my mentor and teacher. They were my teacher at PGI MER Chandigarh. I also owe my gratitude to mentor in pediatric cataract surgery. While I was working with Dr. David Apple, I got opportunity to work with Dr. M.E. Wilson, and I consider Dr. Abhay Vasavada, whatever I learned for the last, I think, several years, more than 30 years, 35 years, is particularly pediatric cataract surgery from Dr. Abhay Vasavada. While you see these children, while they come to your clinic, they come with visually significant cataract occupying even larger area than the visual axis, or it is quite significant cataract. Surgical tips for pediatric cataract surgery. I will take some of the points. Already Dr. Vaishali Vasavada has highlighted. There may be some overlap, but these are the normal cases what we do in such patients. We dilate each of the eye of pediatric of the children to see the morphology of the cataract. Whether it is a zonular type of cataract, or it is a lamellar, or whether it is, because you will detect so many issues such as PHPV, or there may be other some posterior lenticonus, or even complicated cases. So I think I consider it essential to dilate each of the eye. Then we have to select the IOL power. IOL power calculation is quite important, because in these growing eyes, there is likely to be surely, I think, a myopic shift. We have to consider whether to implant IOL or not. As Dr. Vaishali Vasavada said that initially I used to think that okay, it is safe to implant IOL in 9.5 millimeter corneal diameter or more. But now as we grow senior, we feel that what to do, what is the safer limit. So 10 millimeter at present, or if there is any complication during surgery and you cannot implant IOL into capsular bag, I think it is better to defer implantation of IOL in these cases. And there are other issues of marked inflammation, its management, and as well as management of amblyopia. Our goal is to provide a clear visual axis and ultimate visual rehabilitation. These are some, I think, more than 30-year-old photographs. That time you see on the extreme left, there is this PMM IOL. Pharmacia IOL we used to implant that time. Even now we see these after doing primary posterior capsulotomy and implanting IOL in the bag, they have clear visual axis. I will be showing some of the basic steps. What we do, we make first side port incision. And then stain the anterior capsule. Whatever you may be expert in doing the praxis, but this is just to demonstrate. much of the disturbance which occur. Here almost minimal or no disturbance, but still there may be some vitreous traction a bit. Then our aim is to implant IOL in the capsular bag, and IOL of choice is hydrophobic acrylic IOL. At no point of time I have implanted silicone IOL. Of course, PMM IOL several times I have implanted in the beginning. And you find perfect rhexis. While you do perform posterior continuous curvilinear capsular, you may find traction like this. This need that if you put triamcinolone dye, and that will stain that traction, and you end up in round. This is the same child, where you find a round posterior rhexis. And then I will show posterior optic capture. These whatever cases I am going to show is absolutely, these are the normal, not abnormal, such as lenticulas, any of the PHPB or like that. So this is how we do. So here it is staining of the anterior capsule. Main incision, and small nick in the continuing with the continuous curvilinear capsular rhexis, and then removal of the cortex from the capsular bag. And we try to remove the cortical material from the capsular bag. Ideally, you have to keep posterior rhexis also, make it little bigger. So while you capture the IOL optic into the bag, it will give excellent result. And then we have carried out study also in children, although it will not add much, because we can do good continuous curvilinear capsular rhexis and implantation of the IOL, but we have done pediatric cataract surgery in children, and here even location of the side port incision and main incision, where to make, we can choose that. And otherwise, finally confirming the length and position of the main corneal incision and side port incision. And I think this help only in performing mainly the continuous curvilinear capsular rhexis, because cortex is very soft. It will not add much. So they are staining the incision, and here injecting viscoelastic and opening up the main incision. And then of course I think it is not difficult to remove the cortex from the capsular bag. Here here we have not done the posterior capsulotomy with the hematosequin, but manually. But because we can make almost close to perfect, or most of the time we can make excellent posterior continuous curvilinear capsulotomy, then implanting IOL into back. And then removing any of the vitreous tag or viscoelastic from the capsular bag. So this is but we always put in smaller children, younger children, we put suture at the main incision, sometimes even on the side post incision. This is the last video clip. Here, if in a normal child, 5-year-old child should be cooperative. If there is a astigmatism, older children, 5 year or older, because even up to 6 year it is considered, and studies have shown that there may be decrease in the astigmatism. So, at least 5 to 6 years of age group, marking was possible in this child. Staining of the anterior capsule with the trypan blue dye. And performing, I think, repeatedly these continuous curvilinear capsulorhexis and other steps. If we perfect them, it is perfected for life. And this is continuous curvilinear capsulorhexis, and then removal of the contacts after hydrodissection from the capsular bag. And here this is the removal of the contacts from the bag. Here we have also done primary posterior capsulorhexis, size about 3.5 or around, limited anterior vitrectomy, and then implanting toric IOL into capsular bag, and here in this case Callisto is used, and IOL is rotated to the desired position. This is the end of surgery. This is the opposite eye, which was done about documented 3 weeks back. This surgery was done. So this is also a viable option in selective cases. But I think what I feel that long-term follow-up is important in these pediatric cataract surgery children. This is one child which I operated in 1997. That time only it was beginning of primary posterior capsulotomy and implantation of capsular implantation of IOL. Now 25 years later, this child is now doctor. He has completed his MBBS only 2 years back. So I feel that these are the word of the illness which are very important, that young children with IOL in place are a unique clinical responsibility of an ophthalmologist. So long-term follow-up is essentially important. I think these are, so once again I am thankful to Dr. Vaishali Vasavada and Dr. Abhay Vasavada. I feel that family is most important, and because that is our strength. Thank you so much.
Thank you, sir, for those really multitude of tips that you gave us. And does anybody in the audience have a question or a comment? Please, could you come up to the mic, please?
Okay. Do you hear me? Yes. In case you're implanting the toric IOL, do you need to remove the viscoelastic behind the IOL to prevent rotation, or do you optic capture it to prevent any rotation post-operatively? Thank you.
Yeah, definitely. I think question is viscoelastic. Viscoelastic, whatever we put into capsular bag, implant the IOL in the bag. So from behind also, behind the IOL optic, we have to remove the viscoelastic. Of course, front we remove whole, but it is quite important to remove that viscoelastic, because IOP goes high with that viscoelastic in children.
But in the presence of the posterior CCC, how do you do it? I mean, safely.
No, I can answer.
If there's a PCCC, how do you remove from behind the IOL?
Yeah, even then what we do that, because IOL is in the bag, we lift one part of the optic, say superiorly or close to the side port. We lift that up and go behind the optic. That is what I do. And manipulation should be very, very limited.
Any chance of breaking the hyalur membrane? That's
Yeah.
what I would like to know.
Yeah, I think it's a very important question, and Professor Jagatram is very dexterous and he's very confident. He has done thousands and he can do that. And what I do, I'm a coward. So I do PCCC in children under 6 or 7 years. In other words, I judge, is he a laserable child? Will he cooperate later on for YAG capsulotomy, sitting there and keeping quiet? With most of the children, I don't take a risk. So I perform a small 2 millimeter or so posterior capsulorhexis on a toric IOL, single piece hydrophobic, and I don't remove. I don't go behind the IOL with open capsule. I don't care about the IOP. I treat it with mannitol. I always give injection mannitol post, just at the end of the surgery in children where I have not removed it. Thing. And rotation is not an issue actually with this single frog. But you can do as he suggested, but you need to be very careful and decide how. If you rupture once or twice, forget about it. And do so. You decide your own strategy, but your question is very important. Very nice. Thank you.
Yeah, I think I agree that it's better to err on the side of leaving behind some viscoelastic. You can always do a little bit of rock and roll or tap on the IOL, and give. I also like to give topical IOP lowering agents in these eyes, but with all good hydrophobic single piece, the Acrisoft toric that we use, we don't see rotation so much.
And as you say, the vitreous with a small rexis will not come forward.
Yeah,
Even if you go behind, it doesn't come forward. But you be careful. It depends on your experience, skill, and everything.
I think that is a very right word. One has to be very careful.
Yes.
If you don't remove or if you remove. But I go toward the side of removal of the viscoelastic. But one has to be very careful, as sir also said.
Thank
Thank
you.
you.